fearfully and wonderfully made human. Welcome to another episode of the Holistic Counselor Podcast, where I, Diana S. Rice from Through the Valley Therapy, guide you through an intersection of a personal and professional trail where I hope you will find useful information and encouragement as you navigate your own journey toward your mountaintop. Today, I am super excited to introduce to you a unique, nationally certified mental health counselor with over 30 years of clinical experience. Dr. George Wallace-Barnhill has served as a clinical director of drug and alcohol programs, as well as an intensive trauma program for women. He has conducted research on stress and safety in anesthesia and surgery while serving as an assistant professor in anesthesia and surgery at Jackson Memorial Hospital in Miami, Florida. He has taught graduate classes at Nova Southeastern University in the Center of Psychological Studies and Palm Beach State College. Dr. Barnhill's comprehensive non-pathological, can you say it, Dr.?
Pathological?
Thank you. Non-pathological approach helps patients achieve success by helping them understand the connections between emotions, behaviors, thoughts, and perceptions so they can achieve a more rational and positive sense of self. All right, folks, before Dr. B and I get into it, gather around because I've got a story that'll give you some goosebumps. I call it a supernatural God story. I was knee-deep in a tough case back in August, feeling like I was hitting a wall, but refusing to throw in the towel. I just couldn't bring myself to send this client back to a system that had let her down time and time again. So every single day, I poured my heart out in prayer while researching online about the latest on DID and trauma, watching video after video. Now, fast forward to September 29th, I almost turned down an invite to a tiny networking event, but something, call it the Holy Spirit or a gut feeling, pushed me to go, and man, am I glad I did. Big shout out to Victoria and Phil at Dude Breathe Counseling for that one. Sitting at that table, surrounded by strangers, I took a leap of vulnerability and asked if anyone knew a specialist in DID. It felt like an eternity before a fellow therapist spoke up, mentioning Dr. Barnhill. You won't believe it. Turns out he was my professor back in 2002, the one who wowed us with real-life footage of DID clients and taught me the ropes on this complex diagnosis. I was floored, thankful, and without skipping a beat, I shot him an email. The next day, boom, he responds and we reconnect. Since then, he's been my Gandalf, my mentor, sitting in on his session and soaking up every bit of wisdom he throws my way. And here's the kicker. This divine intervention didn't just help me, but the client he's now working with is thriving like never before. It's like fate, synchronicity at its finest. Dr. Barnhill might not realize it, but he's a true godsend. And this whole experience, well, to me, it's nothing short of miraculous. So let's welcome Dr. Barnhill. Hi, Dr. B.
Hello.
Can you tell us a little bit about your personal story in terms of what led you to be in the profession that you are in today? And what is DID? And what do you mean by non-pathology?
Well, that's a lot. Thank you for that wonderful introduction. It's quite surprising and meaningful to hear you make those kind comments, and it's certainly helpful to be able to connect with someone who is on the journey that I was on for many years, starting back in the late 80s, before DID was DID. It was actually multiple personality disorder, which, of course, is a misnomer because DID patients are not multiple personalities. They're actually less than one. And that's the reality of it because dissociation means that you are fragmented. Okay. The degree to which you are fragmented psychologically, emotionally, determines the degree of the diagnosis.
So DID, because that's a new name for it. What's it actually mean?
Dissociative Identity Disorder really gets to the crux of the problem with the diagnosis, which is it is a identity disorder.
Okay.
The patient actually is unclear, and the symptoms that they manifest, which predominantly are memory,
Okay.
identity confusion, and consciousness. And there are 10, 15, 20, 30 different diagnoses that fall, or symptoms that fall under that large, category.
Right.
And the problem with many therapists, regardless of how well trained, is if you don't know what to look for, you're actually not going to see or hear or recognize the symptoms.
So, and I remember learning about this 20-something years ago, and what I'm seeing and hearing and what you've taught me is that a lot of this diagnosis, do you feel like it's underrepresented or confused with other diagnoses?
Well, it is, because first of all, very rarely do patients present to you with these diagnoses. They present to you with borderline, bipolar, ADD, and other diagnoses like anxiety and depression.
Right.
And when and these diagnoses basically can almost be made by anyone. We've all experienced depression and anxiety. So when we hear the symptoms from our patients, it's not hard to recognize, and then we find out if they meet the criteria, and they say, oh, patient's depressed. The problem is that they may be dissociative. Okay. Well, how do you know?
Right.
The patient's not going to throw those symptoms out because they don't even know that they're dissociative symptoms.
Right.
So it's the one diagnosis or category of diagnoses, including PTSD, where it's up to the therapist to move forward because you have reason to suspect that there may be more to ask for. Everyone with DID has depression and anxiety. So what?
Yeah.
But that's not the terminal diagnoses.
Okay.
And what I tried to teach my students for many, many, many years is to get the terminal diagnoses.
So how would you do that? Like, say there's an intern or someone that's new in the field, and they didn't, because in college you don't learn all these things, right? It's experience. And so you're thrown into community mental health, and here you are. And like, even with the clients I had, it took a while. It took a while for me to realize, oh, this is exactly, because I took, did assessment after assessment, right. And I'm non-pathological as well. And so can you explain what that means?
Well, actually, I think you suggested to me that it took probably a year before you felt pretty comfortable that your patient had dissociative symptoms, much less may have been DID. And of course, you can be dissociative with dissociative symptoms, including having alters without being DID.
Right.
Okay?
Yes. So here's the situation too, alters, right?
Yes.
We end up having, you seeing a client and you're seeing these multiple personalities and these alters. And I think what happens with a lot of clinicians, they're seeing this and they're overwhelmed and they really don't know how to treat them in a respectable manner.
Well, the problem is they're not seeing them.
Okay.
or at least they're not aware that they're seeing them. You see?
Okay. Mm-hmm.
And many, particularly newly licensed therapists, look, the master's programs particularly educate you about dissociative disorders.
Right.
There's no master's program that I know of that actually teaches you experientially how to actually treat someone. So even if you're pretty good at diagnosing, that's a far difference than, okay, now I can treat it. You can read how to do brain surgery, but you really can't do it. So the experience is missing. And unfortunately, even though all therapists, whether they be psychiatrists or psychologists or mental health counselors or other trained psychotherapists, don't get the experience. They go to a treatment center and they usually get their experience through a drug and alcohol treatment program, maybe a psychiatric facility or a drug eating disorder clinic.
Right. Or community mental health, like a Henderson clinic or something like that.
Exactly. And actually at Henderson Mental Health, you certainly get a plethora of diagnoses, but it's unlikely that you'll get specifically trained in how to diagnose dissociative disorders, much less DID. And at a treatment center for drug and alcohol, there's no way that you're going to mostly learn educational group process to work with the patients who are there for addiction or alcoholism. And the same with eating disorders. It's totally focused on the eating disorder. And my hypothesis for 35 years has been that neither alcoholism or addiction or eating disorders is actually a disease. And I think it's a symptom. And the real problem lies behind why the person has these issues in the first place. Because the symptoms are almost always historical.
Right.
And if you track the symptoms back to when they began, then you can start looking at the circumstances under which the person started having difficulties with drugs or alcohol or eating or something else.
Right. So tell me, okay, so say that I am a client that comes to your office for the first time, right? And I've already have gone through the system, like a drug and treatment center or a community mental health, and they've given me like 2 or 3 different diagnoses, and I'm on, 4 different medications, and I come to you. What would be the first thing you would do?
Well, actually, the first thing I would do is exactly the same thing that every licensed clinician out there should do.
Okay. Which is?
To listen. Because every therapist out there thinks they know what to do. Because if you've been in the system, you came to me with perhaps diagnoses, more than one, as well as perhaps medications.
Right.
Well, I never, ever accept a patient's diagnosis that they bring in to me.
Ooh, that's a little controversial, no?
No, it's not controversial. If I have to go to court and I have to justify that a patient of mine has a specific diagnosis, I darn well sure want to make sure that I've diagnosed the patient on my assessment and evaluation, not on someone else's assessment and evaluation.
True.
Regardless of who they are. And probably, 8 or 9 times out of 10, I may well agree with the previous clinician. I'm not saying they're wrong, but I'm saying I want to make sure that I do agree, and why do I agree? But if I have any reasons to suspect, particularly if you come in and you've been diagnosed with ADHD and bipolar, perhaps borderline, I'm going to say, well, why don't we just scrap that for now and let's you and I decide what's going on, which will immediately put the patient at ease. There's 2 things that every clinician must do in the first session.
Okay.
You have to determine whether the patient is psychotic.
Right.
And you have to find out if they're suicidal.
Exactly.
We all know that.
Right.
That's our mission. That's why we have a license. We have a license for basically 3 reasons, which we can do legally and other people who aren't licensed cannot do, at least legally.
Right.
I mean, anybody can diagnose you, but that doesn't mean it's valid.
Right.
So what we're licensed to do is a clinical assessment and evaluation, a diagnosis, and a treatment plan.
Right.
And then we are licensed to provide treatment, which is called psychotherapy. Okay?
Yeah.
So that's the lane that I'm in, and that's what I do.
Right.
I don't do alcohol treatment. I don't do eating disorder treatment. If someone comes to me who's in recovery, and you start talking to me about your drug problem, I'll say, you need to take that back to your treatment team. I don't talk about that.
Okay.
If you have an eating disorder, the last thing I want to do is talk about how you're weighing out your food.
Right.
Because in my mind, that's a symptom of the real problem. When did you start having an eating problem?
Okay.
Oh, Dr. Barnhill, I guess I was about 12 years old. Duh. I wonder what was going on. Let's check it out.
Okay.
And a borderline diagnosis is exactly what it means. It's the borderline between what? Neuroses and a real diagnosis. So why don't we find out?
Right. And how do you find out?
First of all, I think particularly with borderlines, now that you ask, and the research that I've read, and any of you can look this up, about 87% of borderline patients are dissociative.
Wow.
Now, how would you know that if you're a clinician? You need to ask the questions. The basic problem with newer clinicians who don't have experience is they're afraid to ask the questions in the initial clinical assessment and evaluation.
Right.
If you have any reason to suspect that the patient may well have some history of abuse, you have every reason to begin to ask questions.
Right.
If the patient says no, then you move on. But most therapists don't even ask because their anxiety goes up.
Right.
And they would much rather you go get on some medication.
Wow.
And then they could relax.
Oh.
You see?
Okay.
So particularly with borderlines, the new therapist, particularly if it's a psychiatrist, almost immediately changes their medication, which infuriates a patient.
Right.
But my initial job with anyone who may well be borderline or at least have those symptoms is to put them in control of their medication.
Okay.
Why don't you tell me what works for you, and I'll call your psychiatrist.
Okay. Well, some of them, I would say some clients I've come across don't know how to advocate for themselves, right?
Well, you can't put it on the patient. The problem is we in the mental health profession are not confronting these people with symptoms because you're not familiar with them.
Okay.
So I think any therapist who's and any of you that say you're not working with traumatized patients, you're blowing smoke because all of you are. You're just not recognizing it. Look at the percentages of patients that have major depression or severe anxiety and tell me they're not suffering from stress/trauma.
Right.
I've asked patients a very significant question to begin the process. What was your first memory?
Okay.
What do you mean, Dr. Barnhill? What's your first memory? I know it's kind of a stupid question, but what's your first? You mean in my life? Yeah. Well, I've had patients tell me their first memory wasn't until they were a teenager.
Yeah, true.
Or 10, 11, 12. Mm-hmm. I had one lady tell me she didn't remember anything before the age of 16. Now, as a therapist, unless the person has an organic medical problem,
right,
or they're so they really have a physical problem, then there's no other. At least you have reason to suspect, to say, wow. I mean, the first patient I diagnosed with MPD back in 1988 said she had a perfect childhood.
And how'd you find out she didn't?
Well, I began to ask questions about her childhood because she had no memory for most of it.
Wow.
And that's why people won't like this either, perhaps, but that's why cognitive behavioral therapy is very minimally effective with working with trauma.
Right.
Because your conscious memory is a defense, and it protects you from knowing, just like a dissociative patient is protected from knowing that they have parts or alters inside that have been abused.
Okay.
So the patient has no memory sometimes.
Right. I mean, that makes sense. And ouch, because I'm a CBT therapist.
If it's for the proper diagnosis, it works perfectly.
Right.
The same as having coping mechanisms. Coping mechanisms like affirmations and mindfulness and cognitive behavioral therapy and exercise. It works minimally, and it only works temporarily, but it does not deal with trauma.
So what does work with trauma?
Real trauma therapy, which in my estimation is less about the trauma.
Okay, and more?
Well, everyone says, or many people try to get the patient to keep it in the past and to let it go. Well, it's almost idiotic to think that someone sitting in front of you who's 20 to 55 years old, you don't think if they could have let it go, they wouldn't have already done it?
True.
So it's punitive for you to verbally, as a patient, to say, why can't you just let it go? I'm going to help you. I'll give you some medication, and we'll help you to repress it by doing affirmations every day, by looking in the mirror and telling you you're handsome or beautiful or smart.
Okay.
That's like taking an aspirin for a migraine.
Okay.
It just doesn't work. And after they've been through 3 or 4 therapists
right.
and many different medications and they're desperate, then they'll go to a trauma therapist. And if they come to me, I'll say, well, I don't do coping mechanisms. And they say, thank God.
Okay.
So in other words, the trauma needs to be addressed. However, I don't treat the trauma.
Okay. What
do I treat?
Yeah, what do you do?
Because the trauma is already over.
Okay, right.
Anywhere from 3 years ago to 30 years ago.
Right.
The trauma is already completed. So the logic among lay people is that somehow or other you should just keep it repressed because you can't do anything with it.
Or the somatic movement of it. That's a thing.
Another thing.
Yeah.
I'm not interested in, I am, but I'm not interested in directly helping the person to deal with the trauma itself.
Okay.
What I'm interested in is the effect that it still has on you.
Okay, right.
Which is almost always emotional/somatic.
So how do you?
So I'll say to a person, have you ever felt this way before? Let's say it's extreme anxiety and panic and fear.
Yes.
And obviously they'll say yes. And I'll say, how long have you felt that way? Oh, Dr. Barnhill, my whole life. And I'll say, well, that's actually not true. You really weren't born that way.
Okay.
Did you have this last year? Yeah. When you got married? Yeah. When you graduated from college? Yeah. Did you have these symptoms when you were in high school? Oh, yeah. Oh, now I remember. Okay, tell me. Oh, you were 12 years old. Your parents got a divorce. How did that affect you? Oh, I just moved on and I did this and I did that. But that's when the person started having anxiety.
Okay.
And of course, they're usually lost in the shuffle when the family's going through something, psychologically, emotionally traumatizing, like a separation and or a divorce. Now, it's not outright, straightforward, life-threatening, but to the child, it can feel that way.
Right.
And you do not have, it's not required that you were in a real war to get PTSD.
Right.
So young people at any age can have symptoms of PTSD.
Right, complex PTSD or childhood PTSD.
Childhood PTSD,
yes.
And it doesn't heal. It doesn't go away if it's not addressed. The person, him or herself, obviously learns to cope by rationalizing and minimizing, pretending it's the same that everybody else has. And my situation's no better or worse. That's what I did. I thought everybody dealt with the things that I did. And the lady I was telling you about, the first patient I diagnosed who thought she had a perfect childhood, I said, I hate to ask you this because it was the first time I directly was focused on all the research and treatment programs I had gone to and medical conferences and visiting trauma therapists in Texas, in Washington, D.C., and in Philadelphia, all the people who are writing the books about dissociative disorders. So I said, she said, Dr. Barnhill just asked me. And I said, you don't hear voices, do you? And she said, oh, yeah, doesn't everybody?
Wow, that was her normal.
And so I said, how come you never told anybody? Nobody ever asked.
Right.
So we as therapists must begin to ask. If it's not, medical doctors rule out diagnoses all the time.
Right.
Why do we think we have the answer just because the patient presented with 7 of the depressive symptoms to qualify the patient for major depressive disorder? It's probably accurate, but what if there's more?
Right.
Well, nobody goes any farther. They just start treating you for major depressive disorder. They start using cognitive behavioral therapy. And, I spoke at the University of Pennsylvania, and who's the CBT guy? Who is that guy?
I don't know. That was so long ago.
Aaron Beck.
Oh, yeah,
Aaron
that's
Beck,
right.
yes.
Him.
Well, I
so
remember,
many different modalities out there that you have to memorize to pass the test.
He's fantastic. And
right.
I met him and met his interns and when I was with the University of Miami Medical School at Jackson Memorial Hospital. So, and it works, okay? But it doesn't work for trauma.
Right.
So what if your depressed patient is also coping with dissociative symptoms and you're not aware of it and you keep going back to all the cognitive features and the person can't do it, and then the therapists get frustrated. And then, of course, they say, maybe you need more medication.
Right.
And of course, that's what pharmaceuticals are doing to us right now.
Yeah.
If your depression medication isn't working, we have an answer.
Right.
We have another one that we can add to it. We'll make things okay.
Yeah.
And then you see the person skipping down the street. Everything's fine now because I'm on double the amount of medication.
Yes.
It's ludicrous.
Yeah. I mean,
nothing against medication.
Right. Medication has its place. We know that. It's the last resort.
Yeah.
That's crystal clear. It's like the last resort, not the first thing to jump on. Unless you want to just manage symptoms for the rest of your life, right?
No.
But most people that go into therapy actually want to get to the root cause of what is ailing their poor mind.
Exactly. And that's why I think we need to listen and pay attention. And if you have reasons to suspect that there's something else going on that is connected to or related to any kind of traumatic experience, the patient's not going to bring it forward. And of course, there are some scales, which I'm sure you're aware of. We may not talk about them today, but we use depression scales and anxiety scales.
There's even a dissociative, the DIS
there's
assessment that I know I used before I think I did every assessment possible before I finally said, yes, this client has DID.
Well, the first one, if you're suspicious, a therapist is suspicious, should use the ACE. And that's the
Adverse Childhood Experience
scale. And then if the person has positive responses and you say, wow, maybe I should try the PTSD scale. There's a national scale. The patient can fill it out. You can evaluate it. And then if you're more suspicious and you start getting more information and the patient begins to open up a bit and you say, hey, I may be onto something, you use the dissociative evaluation scale, which goes through the primary symptoms of dissociation, which have to do with memory, identity, and consciousness. When you the patient starts opening up, you know that you really have something.
Right. And so when I was with you, watching you do your thing, that right there, how did you know how to do that? And are you able to teach that to an intern or a therapist who's interested in really knowing how to? Because to me, like, every client is a unique thumbprint, right?
No, there's no one client that's like any others. And we must, every patient that I've treated since 1988 and began to get into the dissociative area, treating dissociative symptoms as well as DID, initially multiple personality disorder, every single one is different. Every patient has a different internal system that is usually made up of a minimum of 17 to 20, 30, 40, 50, 60, 70, 80 different alters. And one of the main things you need to do is to help the patient to stop creating more alters.
Okay.
That's critical.
That was like something I didn't know. Even though I read and I was researching, it's like, I guess when I was in the midst of it, I was trying to just find that textbook, because that's like, okay, I want to help my client. I know that she's suffering and I want to learn more and more. And so I'm like, oh my gosh, I think I even contact someone in England, the CTAD clinic.
The first thing I do when I discover that I may have a dissociative patient, much less DID, is that I make my mind a complete blank and I throw out any cognitive thoughts that I might have of exactly what I should do, because we are powerless. And that's the feeling that most therapists have when they work with dissociative patients, is they feel powerless. Well, guess what? You are. You must engage the client. The client must take responsibility for what's going on inside, and they will do it if you can connect with them and if they know that you will not leave them.
So you're talking about abandonment.
Exactly.
Okay.
So it's critical that you establish a therapeutic alliance. Gee, where have I heard that before? That's one of the cardinal things that you do, regardless of the patient. If you haven't established a therapeutic alliance, they're going to be seeing somebody else in about 3 weeks.
Right. And I think that might be the frustration too, if you're a therapist who's like working with insurance companies or in the community mental health, where you just don't, you have six sessions or 12 sessions, and then that's that. And you have to hurry up and take as many as you can. And like, how do you encourage anyone or interns in the mental health field?
Well, I remember when I first started working with multiple personality disorder, literally 2 or 3 or 4 times a month, because I was treating 14, 15 multiple personality disorder patients a week.
Wow.
For 3 years. And I would get calls from hospitals all the time because they were taken into the hospital for doing strange and unusual things, and families or friends or somebody didn't know what was going on because an alter came out that was homicidal or suicidal.
Yes.
Or cutting.
Yes.
Cutting is a significant symptom.
Yes.
And they wouldn't know what to do with the patient. I would run to the hospital and try to stabilize them because they were terrified. And usually it's a 12 or 13 or 14-year-old male alter who's trying to protect whoever the person is, usually a woman, not always. And, you have to be able to respond. And I'm getting to a point that it's critical. It's critical that you're willing to acknowledge what's going on and that you feel immobilized and that you need the patient's cooperation. The patient in front of you must be willing to finally face their fear.
Mm-hmm. Okay.
Because it's fear that protects and keeps the alters from coming forward because they keep all these secrets.
So, and I think that could be overwhelming, say, for a client, like all of a sudden you're seeing this human being in front of you, and I've seen it, like they change, like eye color. I mean, there's just
everything.
Their whole chemistry, their whole biology is changing right in front of you, and then they could become this 3-year-old child. And
in a heartbeat.
Yeah. And how do you encourage a therapist to continue to work with clients like this without giving up that right
Because
there?
It's probably one of the few diagnoses in all of the DSM that's treatable.
What?
The symptoms go away. When the patient is integrated, they no longer have the diagnosis.
True. I mean, yeah.
With what other diagnoses can you do that? I'm waiting.
Yeah, I guess.
That's what I'm talking about, non-pathological. It's not a disease. They're not crazy.
Okay.
They're dissociative.
Right. But I guess I think it's those that don't understand this.
Well, not understanding doesn't mean it's not true.
True. It's just a complexity of because we're in the field, so when we see somebody, we know how to treat it. But I think it's the stigma I'm trying to get at. How do we break that stigma?
When you say you're in the field, the truth is, let's say you're in a football field. You're in one corner of the football field. You're not looking at the whole playing field.
Right. As
licensed clinicians, we're responsible for all the diagnoses that are in the DSM-5.
Right.
So it's in the DSM-5. So if you don't know about it and you think you're not going to treat it and you're only going to treat what you call the
worried well,
you're kidding yourself.
Yes.
You really are, and you're not doing what it is that you're licensed to do, and you certainly don't need a license if you don't want to do that.
So how do we encourage those that are coming up? Right? Especially with this, like I said, I'm trying to help people break the stigma and not be in fear, even if you're a mental health counselor or not, like someone listening to this and going, oh yeah, my uncle, wrestles with this or whatever. How do we get it to a place where they can understand it better without just going straight to the, oh my gosh, they're crazy. Look at them talking to, whatever, or the fear. There is a fear factor, and especially I come from the faith-based community. Some people just automatically think these are, oh my gosh, that's the devil. And I'm like, no, you got to understand the whole picture, people.
Well, that's unfortunately, and forgive me, but that's the easy way out, really. I mean, it's always easy to say, well, that's the devil. Even if you actually believe in the devil, that's an easy way out because you're giving up all your power.
Wow.
And you don't have to give up your power. You are not powerless with this diagnosis. You're powerless if you think that the system is going to take care of you.
Wow.
You may need help, but if you find somebody that can actually help you, not only can you decrease, minimize, or become a patient who's completely integrated, joined, blended, bonded, and all the parts inside, all the situations for them have been resolved. all the traumas have been uncovered, then the person is a whole person.
So how long do you feel like a person would, with a DID, like, can you give them some words of wisdom or hope if they feel like they might be wrestling with this?
Well, if they're ready to face their fears and stop doing what doesn't work, get to a therapist who can actually treat trauma.
But where do you find one?
Well, I guess you go on to the psychology sites and find
like Psychology Today?
Yeah, and find therapists that treat trauma. Now, unfortunately, many of them, particularly those who use EMDR,
right,
will say they're trauma therapists, and they can treat trauma, but EMDR is essentially for single event trauma and for phobias.
Okay.
It's not for chronic, complex PTSD or multiplicity or DID.
Okay.
And the therapists who the only skill they have is EMDR are going to run into problems because I've used it many times. I use it myself, but there are times when the patient says, Dr. Barnhill, this isn't working.
Right.
And then now what are you going to do?
Yeah.
And I remember this one patient I had when I was not a patient, she was a student in my class at Nova, and we were doing group therapy like we did with your class. And she wanted me to evaluate something with her in her life. She was a single mother with a couple children, and she remembered a trauma, and she wanted me to use EMDR to get rid of it.
Yeah.
And I did. And 20 minutes later, she had no significant trauma feelings related to that experience. And I said, well, let's make sure. Let's just go through it one more time. And all of a sudden, she regressed to the age of 7.
Wow.
Right in front of us, sitting in class. And she said it was dark. And she was somewhere at night on the street, sitting on the curb, all by herself, terrified.
Okay.
And to this day, I can still remember her saying to me, you better not leave me. Now, if all you know is EMDR, you're dead in the water.
So what would you do at that moment if you are a therapist who like has this one skill only, or like within a client, this happens to a client, what do you suggest they do?
Well, I suggest, in that situation, if you don't know what to do, you're
Call
not,
Dr. Barnhill, my Gandalf.
Well, you need more than that. I mean, to be honest with you, I spent 10 years doing this on my own. Okay. Traveling to visit Richard Clough and Colin Ross and
who
Richard
are these
Lowenstein.
guys?
These are all the icons who've written all the books in 80s and 90s and early 2000s. They ran the International Society for Dissociative Disorders. They gave conferences. I presented a paper at the Dissociative Conference in Orlando back in like 1992 or something like that. Okay. And these were the people I learned from. I went to Texas with Colin Ross and spent 2 weeks watching him work with dissociative patients. Richard Clough was at the University of Pennsylvania in Philadelphia. I hounded him for 3 days until he let me go on rounds with him. And Richard Lowenstein came down from, I think, NIH or someplace in Bethesda, Maryland, and I worked with him for a weekend. I had all these people on speed dial, so that when I had a dissociative patient in front of me and I got stuck, I would call them on the phone, and they would help me deal with it. So after 10 years, I was able to experience many of the things that are kind of pitfalls that any therapist would go through that you have to learn how to modulate.
So are you able, or do you have some kind of training for us?
Well, I would definitely suggest initially that you read Trauma and Recovery by Judith Herman.
I'll put that in the show notes. Okay,
MD, Ph.D. And I would read The Body Keeps the Score by Bessel van der Kolk.
Number 1, yes.
I still have my notes from the first lecture of his I went to in 1986, I think, when he first started doing research with Judith Herman. Okay. I would certainly read Hans Selye and Stress, a Canadian endocrinologist. All right. I would read Bowlby, Attachment Theory. Yes. That's where all this comes from. And I would learn how to trust yourself more. Your education in and of itself does not help you to treat dissociative patients, but I don't think you should do it unless you have the education, nor do I think you should do it if you're not licensed. So that's the good news.
Right.
The bad news is you're naked and afraid.
Yeah, for sure.
But that doesn't mean you shouldn't do it.
That's true.
That doesn't mean you shouldn't. And your patients need you. And DID is as common as psychosis.
Oh,
So that's approximately 1% of the mental health population. So if you think you're going to be in therapy and treat a random patients who come to you for a period of years, I guarantee you're going to run across these patients and you're going to miss the opportunity to treat them.
yeah, I understand that completely. Like I've seen it, and I just in my personal experience as a therapist, it's just when you have a patient client like this, you know, I didn't want to throw anyone back into a system that totally traumatized them even more on top of the trauma they already had.
No, exactly.
And so that right there, I'm thinking like maybe if you are in Florida, that they can contact you and you can give them like become their Gandalf or something like that.
Well, the
for
other
a
thing
fee.
is, the other thing is, I've found out that this can be done online. I never believed that it was possible, but
Wow.
over the past year or year and a half,
Okay.
I've been treating dissociative patients online from other states in the United States, and to my happiness, it's actually working. It's still not the same as having the patient come to you in your office. But if the patient is motivated and they're willing to face their fears, then it can work.
Okay. Well, listen, I mean, I know I can sit here and talk to you forever, but we're going to have to start closing this
Okay.
episode out, and maybe I'll have Dr. Barnhill back, or we might be starting something together in the future. I'm not sure, huh, Dr. B?
I certainly hope so, yes.
He also has a book called The Jukebox of Life. It's his memoir, and it's a very interesting read. I don't know. I guess I am on video, so here we are. And I will put that in the show notes as well. So before I totally close it out, is there one or two sentences you would like to say to the audience?
Basically, I think what I would say is if you're ready to help your patients to stop doing what doesn't work, then I suggest you look into trauma, period, much less DID.
Yes. And I just did an episode on CPTSD and ACEs only, honestly.
Oh,
and
absolutely.
I think that's coming out, well, soon. Look for it. All right. So as I close out another episode, remember, sweet listener, to trust in the Lord, guard your heart, and renew your mind. Bye.